Okay. Good morning, everyone. Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician at Gates Way to Health. This morning, we're talking about Meniere's disease and its connections to food allergies and autoimmunity. And we're joined by Kathy. Good morning, Kathy.
Good morning, everyone.
And so we're circling back to Meniere's. We talked about Meniere's a few weeks ago. We talked about the differentiation between Meniere's and vestibular migraines. And we just wanted to explore Meniere's in a little more detail, probably because in that broadcast, I didn't do as good a job as I could have with visuals. And Kathy and I were talking about it afterwards. And today we're going to bring in some visuals to help with understanding what exactly is happening with the inner ear with a Meniere's patient. So what comments did you have, Kathy?
Well, I think we need to revisit the pathophysiology of Meniere's.
Okay, so with that, I will bring in this lovely diagram for everyone on YouTube, everyone on Facebook. Scoot back a little bit. It's always inversely related in the direction I turn the poster, so I'm almost getting used to that. So here's a diagram of the inner ear. Now, you can see out here, you can see over here is the outer portion of the ear that most of us would designate as the ear, and you see farther in is going to be the inner ear. This right here is your cochlea. This is where you hear from, whereas this is your vestibular apparatus. Now you have fluid in this inner ear organ, and the fluid helps with transmission of sound waves in the cochlea. It also helps with little motion detectors in the vestibular apparatus that can sense which direction your head is turning. Now, in something like Meniere's, and just some basic vestibular physiology, with Meniere's disease, let me see, I'll turn the camera here a little bit more. With Meniere's disease, we have swelling of this whole organ, and particularly it's just not draining. Now here we have different semicircular canals. You have 3 different semicircular canals in the inner ear that sense motion. You also have this area right through here. This is called the utricle and the saccule. And this organ detects linear translations. It's also involved in detecting tilts. So I'm going to take the poster down, tilts specifically. So are you in a train car going to the right-hand side, looking out the window? So it's like you're sitting facing the window and you're going to the right-hand side. Or are you tilting your head to the right-hand side and not moving at all? And your brain has to delineate the difference between those two, which may actually seem simple, but it's actually pretty complicated. So that portion of the inner ear, the utricle and the saccule are very important in that differentiation. And if you've ever gone up in an elevator and you felt your stomach drop, that's because this part of your inner ear is getting activated. It's called the otolithic organs. So when we have Meniere's disease, basically your cochlea and your vestibular apparatus start to swell. So there's a lot of swelling in quote unquote the labyrinth. And the swelling in the labyrinth then can lead to auditory symptoms like tinnitus. So you may have roaring or ringing in your ear that's really loud. It's often accompanied by pressure in the ear referred to as oral fullness, and it can be associated with attacks of vertigo. So those are the cardinal symptoms of Meniere's disease. Some people have more of one of them or 2 of them than they do of others, and they can vary with different attacks. Sometimes it may be more tinnitus, sometimes it may be more vertigo. Also, the vertigo associated with Meniere's disease is not short-lived. Meniere's vertigo typically is lasting 30 minutes to 4 hours. So if you can imagine coming off a merry-go-round and that spinning that we've all experienced and having it go on for hours, you can begin to realize what an impediment and how really miserable this condition can cause someone to feel. So that's why Meniere's disease is important. And this is why if Meniere's patients are under good medical control, lots of times they opt for surgeries. They opt to have their inner ear literally ablated, where they may inject an antibiotic that kills the inner ear called gentamicin. They may have a surgery going in to cut this whole thing out, or they may have their vestibular nerve right here transected to where they can't sense any motion in their inner ear and all this crazy stuff going on with the swelling in the inner ear. Does that make sense, Kathy?
Yes, it does. And I read, it says there's no known positive reason for Meniere's disease. But, I mean, we know inflammation can be caused in foods. So how do foods that we eat cause inflammation, and can that affect Meniere's disease?
Exactly. So researchers have been wondering about this for quite some time because they started seeing some overlap where Meniere's patients seem to have more medical conditions than other patients. And they saw there's more diabetes and there's more hypothyroidism. It seemed like there were more allergies associated with Meniere's. And a lot of ENT researchers started saying, you know, we see food allergies being associated with things like allergic rhinitis, which is basically, you know, your hay fever. So they're seeing more food allergies in people who have hay fever. Well, the question became, well, can you take somebody off of their food allergies and will their hay fever be better? And so researchers started investigating those associations, and basically what they found in 2012, a big article came out in the journal Laryngoscope, where they did just a skin scratch test. Most of you have some familiarity with it. I know I have had it because I was an allergy sufferer when I was a kid. And basically they scratch your skin and they see if you react to the stimulus. Well, 57% of Meniere's patients had a positive test for gluten on a skin scratch test. 57%. That's pretty significant. And researchers have also found that Meniere's patients seem to have more food allergies, more other allergic responses than people without Meniere's. So from that, it's now being said in the literature that cost-benefit ratio, basically what's the downside of checking someone's food allergies and then saying, okay, you reacted to peanuts, you reacted to wheat, you reacted to almonds, and you react to soy. You're not going to eat these foods. What's the downside of that? You know, the downside is not as great, let's say, versus cutting out someone's inner ear, and maybe they have some lifelong consequences of that. So the medical community, and at least the research community, is starting to shift in this model that I'm seeing in the literature. And I've been following this for the last 10 years. 10 years ago, as you're saying, Kathy, I mean, most people would say Meniere's disease is idiopathic. We really don't know the cause. Then it started coming out saying, well, we think a small percentage of them have autoimmune problems. Then another few years went by, we think a small percentage have allergic problems. Then it started coming out, they're saying, you know, we think most of these people have autoimmune or allergic issues. Anything you want to say on that?
Well, what they say is what not to eat is salt, and you know, which is going to cause swelling,
yeah.
and to stay away from caffeine. You know, chocolate, sodas, whatever. Stay away from that. So, I mean, right there, I think is kind of a red flag that what we're eating, you know, is causing that inflammation. And so it only stands to reason that things like gluten, that we know is kind of a culprit for a lot of folks, would be kind of a root cause, or at least it exacerbates it.
Yeah, and I'm so glad you said that, and you hit on a really big point that I did not touch on. So salt is one of the standard recommendations for Meniere's patients. Why? Because basically there's a significant salt balance in your inner ear that's different from other organs of the body. So the theory is by restricting salt, you're going to restrict fluid volume, and you may help some of the sodium-potassium dynamics in the inner ear. So salt restriction is the most common dietary recommendation for Meniere's patients. But as Kathy is saying, 57% of you have gluten problems. And when you start looking at the other literature, like 2015, I always cite this article, where the world's foremost researcher on gluten basically said that gluten is a poison to the protein structure that binds each intestinal cell together. So basically gluten unzips your intestinal cells from being bound together, which can then lead to pieces of bacteria going into your bloodstream, can lead to other food molecules coming in. This can be a big progenitor for allergic and autoimmune responses. So why wouldn't we just have a standard recommendation of, hey, you know, if you have Meniere's, you should look at gluten. Really, as Kathy and I are saying, if you have any medical condition almost, you should be questioning this, but we're not treating you for that. But it's food for thought, pardon the pun, to really think about these relationships. And then with autoimmunity, did you have anything else on that, Kathy, before I go into autoimmunity?
I just always think when we think gluten that we discussed in length that it's become kind of the first place they go with kids with autism. They have the
Right.
big groups that get together, and the first thing they eliminated was the gluten, because it seemed to be a connecting factor between all these kids. And they've seen improvement with that. So, I know autism isn't Meniere's disease, but I think, again, there's probably some sort of relationship to that. But I did find it interesting on the Meniere's that the age group that they talk about, normally from 40 to 60, could be some younger people, but that even pregnant women saw an improvement during pregnancy, which indicates a hormonal type of thing.
Right. Exactly.
So this isn't a cut and dried thing. There has to be several different legs to this, I think.
You're absolutely right, and there are overlapping features. So some researchers think that a lot of Meniere's patients actually have vestibular migraines, and they think that basically, I didn't really discuss this as well as I could have yet. So your inner ear here, your labyrinth is drained by this little duct called the endolymphatic duct. And so the endolymphatic duct is thought to be kind of clogged for all intents and purposes in Meniere's patients. Or maybe blood flow to the endolymphatic duct is different. So it's like this little pipe that drains your inner ear is swollen, and that's part of the pathophysiology. So some researchers say, well, that's happening because they're having vestibular migraines. So there's a change in blood flow because of a migrainous process. And now everybody's kind of confused as to what is what, and that's where MRI imaging, I think, is going to excel in the next 10 years. It has to be 3 Tesla with contrast focused sequences on the inner ear. But now researchers can go in and say, okay, we actually see swelling of the saccule and the utricle in the inner ear. So then they can say, okay, you have the swelling, the signs of quote unquote endolymphatic hydrops. So you do have Meniere's disease. You're not having migraines. But symptomatically, there's a lot of overlap there. And as Kathy's saying, well, now you're talking about hormonal factors. Hormonal factors are huge in migraines. The whole hormonal piece has been well documented in Maladé-Barkman syndrome, which we've been talking about as well, which some people say is really vestibular migraines. So you can see that there's overlap between all of these conditions, and it's not exactly as precise as we would hope it would be. And sometimes even symptoms looking at like car sickness. Meniere's patients tend not to have car sickness, whereas like Maladé-Barkman syndrome patients and vestibular migraine patients, well, actually vestibular migraine patients are more likely to have car sickness. Maladé-Barkman syndrome patients feel better in a car. So there's all these historical features. I hope I'm not losing everybody, but there's all these historical features that go in to say, okay, is this Meniere's or not? And it's an important diagnostic differentiation because it heavily affects treatment. If you have Meniere's disease, you're looking at salt restriction diets, you're looking at blood pressure medications usually given out by the ear, nose, and throat specialists. They may go in and inject cortisone into the inner ear. If that doesn't work and you're still having horrible bouts of vertigo, that's where then you get referred to the ENT specialized surgeon. For example, this isn't even done in Reno. This is done in Sacramento, to my knowledge. Most of my patients who I've seen have Meniere's before they got here, they typically go to a place like Sacramento to have the surgery done, where they have their vestibular labyrinth basically transected or resected, or their vestibular nerve transected. So yeah, having the right diagnosis and really trying to be steadfast in figuring out that diagnosis is very important for Meniere's patients.
But I've read some things where part of they try to use like vestibular therapy.
Mm-hmm. So with vestibular therapy, and if anyone has questions also, please pose them to us, because I think Kathy and I are in a pretty good role here. So let us know if this doesn't make sense. So with vestibular therapy, here we have our brain. And then I'll hold up the diagram again, and you have your inner ear. So we have the inner ear for all the YouTubers and the Facebookers. Okay. So your inner ear sends 1 million signals per second into the lower brainstem, each side. Each vestibular nerve sends approximately 1 million signals a second. And that's kind of hard to conceptualize. So there's a lot of information coming into the lower brainstem. Now your cerebellum simply down here is the structure that needs to dampen out that inner ear activity. And some people have really healthy cerebellums, and this is where I've seen Meniere's patients, where when I do testing on them, oh my goodness, their eyes are moving involuntarily. They can't keep their eyes still. Well, their eyes are not still when they're in the dark, but when they go into the world, they're actually able to look at something and keep their eyes still because their frontal lobes and their cerebellum can keep their eyes still. Other people do not have as healthy of a cerebellum that I've seen, and so then they can't control their eyes, and these are typically the people in my experience who then have really horrific vertigo, nausea, vomiting associated with the attacks. So when Kathy's bringing up vestibular therapy, the aim of vestibular therapy is basically personal training for the cerebellum. So it's in essence, like, think of like if you were lifting weights, you're doing a bench press, exercising your chest muscles. Well, vestibular therapy is usually having people do things like looking at a target and shaking their head, or they may tilt their head and they're looking at something like a checkerboard going up and down. And the vestibular therapy is designed to kind of create a mismatch in the cerebellum, trying to create air where the eyes slip off the target, and then that is thought to help to reprogram the cerebellum. So that's the vestibular therapy piece. But if you have active swelling in your inner ear because you have all this immune inflammation and you have allergies and the duct's not draining, who knows, maybe you have a vestibular migraine process, you can do a lot of that vestibular rehab, and lots of times people won't feel significantly better because this organ in here is literally swelling and contracting, swelling and contracting, swelling and contracting, creating a very confusing situation for the inner ear and the brain.
Okay, so everything that you've just said, what's come into my mind is a pretty good-sized jigsaw puzzle. And between the Mal-de-Barque syndrome, Meniere's, vestibular headaches, migraines, all that sort of thing that we've been talking about the last few weeks, we could be working this jigsaw puzzle. And, you know, I know we've all done it. Set it a jigsaw puzzle and like, okay, this piece goes right here. I know it. And when you get there, it doesn't fit. So when you're talking about the testing and the different things that have to be eliminated, that's what I'm hearing with this jigsaw puzzle, because I know there's a lot of times I'm just sure that piece is going to fit there, but hey, that's not the case. So we need to move on to the next piece and see if it's going to take that care of filling that hole and taking care of that puzzle. So between the Meniere's, the Day-de-Barque syndrome, Mal-de-Barque syndrome, and all those things that these people we've been talking to for the last few weeks, and I've been reading the comments, there seems to be a lot of folks that are dealing with these issues. Just, I guess, like we've said a couple times here lately, kind of keeping your own little journal. If you've got the dizziness, the vertigo, the nausea, and all that, when you go to the doctor, you need to be able to give him those symptoms, but that'll give him kind of a place to start. But it's not a definite plan. I mean, he's going to have to do some testing to figure out exactly where you're at.
Absolutely. And I would say if you go and see the doctor, you don't feel like you get a full history, then I would keep seeking other doctors. Dizziness is one of the weirdest conditions out there. And for those who have dizziness and Meniere's, you may relate to this. If a patient presents and they're dizzy, like the first thing medically most people are thinking like, oh my gosh, but hopefully this person's not having a heart attack. Hopefully they don't have a heart condition. Hopefully they don't have a brain aneurysm. So we need to take them through a bunch of testing to rule those things out. And I'm going to pause there, and everybody's probably going to be mad. I thought it was cloudy this morning, so I'm going to close the blinds. Give me 1 second, everybody. So there we go. So medically, we have to rule out any possibility of there being a heart attack or something like, an aneurysm. So that's where the dizzy patient, the patient with vertigo, lots of times is then referred to the cardiologist. They go through extensive workups and they make sure their heart is okay. Once that is done, they may go see the neurologist, and the neurologist is there to try and make sure you don't have a brain tumor. If that's all good, you may see the ear, nose, and throat specialist who refers you to the audiologist who does the inner ear testing. And they say, yay or nay, you have this or you don't. But frequently, patients with dizziness, in my experience, feel unheard. So if you're feeling unheard, I would say just keep pursuing other doctors until you find somebody who's really interested in dizziness. Because as Kathy's talking about with the jigsaw puzzle, you have to really want to figure this out. You have to be a good historian. you have to dig into all these little features, because just as I mentioned, like with something as simple as car sickness, that can really help us to differentiate 3 different primary causes, or not primary, but main causes of someone with vertigo or dizziness. And the specifics are very, very important. And then the testing becomes really important too, because as we examine the inner ear, how do we test the inner ear? Well, one of the principal ways we test the inner ear is actually to then inject, and these pictures are backwards on YouTube versus Facebook, so forgive me. But in essence, and we do it here at Gateswood Health as well, is we inject warm or cold air into this portion of the ear. So you literally take like what you would look in the inner ear with, like an otoscope looking thing. It's called a caloric, and then you start shooting warm or cold air into this inner ear. What does that do? It creates a convection current in the inner ear, which causes the fluid to move. So if you put warm air into the ear, it causes the fluid to move one way. If you put cold air into the ear, it causes fluid to move the other way. And it's funny, when I was first telling my mom about this, she's like, no, that can't be. It can't be that simple. And I was like, it is that simple. No, this is well documented. And this is actually how doctors diagnose someone who's had a horrible traumatic brain injury if they're brain dead. Because if somebody is brain dead, they'll inject ice cold water into the inner ear. And if the eyes don't move at all, it basically means that their brainstem is no longer working. With that being said, the caloric testing is very, very important for sensing how much damage has been done to the vestibular apparatus. So these convection currents can tell us a lot about the damage to the vestibular apparatus. And if you have more than a 25% decrease in one ear, then that says there is a significant amount of damage. And then frequently Meniere's patients have been through hearing testing, and Meniere's patients will have low tone hearing loss. So that's also an important feature in the diagnostic workup. But as Kathy is saying with the jigsaw puzzle, now we can do MRI imaging and actually see the inner ear and say, okay, is it swollen, is it not? But you have to be going to an imaging facility that does that type of work and have a radiologist who is accustomed to reading this. Because again, this is the newest of the newest stuff.
Right, because the stuff I saw online says MRI cannot detect it. So,
right.
And so apparently that's older stuff.
That's older stuff, yeah. Mm-hmm.
The thing I was wanting to get to was, I was wondering, okay, if I know I have ringing in my ears, I am dizzy, I have some nausea, I have a fullness or pressure in my ear. If I write that down and give that to the doctor, will that help me eliminate going through all these other tests of heart attack or brain tumor or whatever, so that they can hone in on something like Meniere's disease faster?
Yeah, I mean, I think a good description of your dizziness is important. And this is where a lot of patients come in kind of with their feelings hurt, because they say, you know, I saw Dr. So-and-so and I told him about my dizziness, and he said, are you dizzy or do you have vertigo? And the reason why is that because dizziness patient, it's hard to describe. It's talked about throughout the textbooks. Dizziness is hard to describe. What do you feel like? I don't know, I'm dizzy. Well, that doesn't help much, you know, for the doctor's standpoint. But, you know, is the room spinning around you? Not, okay, so is the room spinning around you, and for how long? Versus, is the room spinning around you, did it stop and now you feel dizzy? Those are really important historical features that you can relay to the doctor, because it's all about time. So if you lay in your bed and the room spins around you, but then it stops, but then you're dizzy and you feel weird for a week, that's more consistent with benign paroxysmal positional vertigo, which is where you get little pieces of calcium carbonate, i.e. think like sand, that dislodge and go into other canals in the inner ear where they shouldn't be. You move your head, you lay down, the crystals move, they have a specific gravity heavier than the fluid, so it causes the fluid to move differently, and then you get vertigo. So there's that piece, versus you come in like Kathy is saying, you say, you know what, I have these bouts where I feel fine, and then I have ringing in my ear and it feels full, and all of a sudden like the room starts spinning, it's spinning for hours, and I'm vomiting. Vomiting is an important historical feature. So tell your doctor that, and it's going to be more synonymous with Meniere's. Whereas if you just go and you say, you know, I'm dizzy, I'm really dizzy, I don't know, you know, now you're going to go down the rabbit hole where your doctor's like, oh my goodness, I have to rule all these things out to make sure that this person doesn't have something life-threatening going on.
And I think we've missed one piece to the puzzle that I read, and that there is a genetic predisposition. I mean, this is something that can be congenital.
Yeah, and I have seen genetic cases
if your grandma's had it, then you need to tell the doctor.
Always, and that's where the medical history, the family history, past medical history, allergies, medications, all these things have to really be looked at with a Meniere's patient, really with any patient. But as I'm reading my new favorite pediatric neurology book, this world-renowned neurologist is basically saying, we all know the history is the most important thing, but because of insurance, doctors aren't allowed to take a history anymore, not the way they need to. So then this gets glanced over. So for all of you out there, you can help your doctors by saying, yeah, grandma had dizziness as well. Now, lots of times back in those days, people didn't go to the doctor and diagnostics were not what they are today. So if you had a relative with vertigo who complained of dizziness, who had ringing in their ear, or they were deaf, then you definitely want to tell your doctor that. And we had a question, Kathy, can ringing in one ear be part of Meniere's? Absolutely, for sure. And lots of times Meniere's is unilateral. It's in one ear. It can spread to the other ear. It can be bilateral, but usually it comes on in one ear. So if you have ringing, if you have pressure in your ear, a sense of fullness, and you have attacks of vertigo, you really want to think about Meniere's. And again, vertigo is room spinning around you. Dizziness is I feel dizzy. I don't know where I'm at. I feel like I'm moving. So those are the basic differentiating factors.
Okay. The other thing I would think we'd want to stress to the listeners is the fact that, yeah, you're going to have different bouts of this, but don't blow it off, because you can be losing hearing while this is happening.
Right.
And you don't really want to go deaf. I'm assuming these people that are having these surgeries have probably already lost, if they're taking that stuff out of the inner ear, they've already lost their hearing.
A lot of them a lot of them have lost their hearing, and sadly, the loss of hearing is the least of their problems. Usually those are people who have horrible, intractable vertigo, and it really ruins their life. I've seen some patients where they have had vertigo for 23 hours a day. Laying in a bathtub, 23 hours a day of vertigo, vomiting nonstop. I mean, can you imagine how awful that would be?
I can't even take the stomach flu for 24 hours.
Me either.
The idea of that, like I said, even when I get seasick, it's, I have seen men as big as you look at me and go, don't feel bad. I wanted to jump off the boat too, because I felt so bad. I'm like, okay, you're 6'4" and you're 250, and you're supposed to be this big fisherman, but yeah, okay, please give me release from this feeling.
Right.
And that's what we're saying. These folks aren't getting that release.
No.
So,
they're not. And that's why they go to these extents. Yeah.
Yeah. So yeah, if we can get them relief faster, if we can do the testing, if they can get to the doctor and figure out what's going on, then. But it's still. I mean, it's. I don't know. To me, it's not an exact science of what they're going to do for it. They've got the 3 or 4 different medications that they're going to try, and they might do some exercises. And it did say that people who exercise do better with this, people who do aerobics.
Mm-hmm. Right.
Is that something you've seen?
It is, because a big thing with the inner ear is what they call vestibular compensation. So in essence, the more you exercise, the more active you are, the more your cerebellum gets stimulated. So they can literally go in and seemingly an otherwise healthy person, and they can cut the vestibular nerve going into the brainstem. And in 7 days, that person should be basically fine. They're going to go through a few days of hell, so to speak, where they're having nonstop vomiting, horrible vertigo, but actually their brainstem will adapt to the lack of vestibular signals. And they found that exercising, getting up, being active, not just laying in bed, is one of the best things that person can do. So if you have Meniere's and you can exercise is great, because it's going to help your brain to adapt to the vacillating signals coming from the inner ear. So that's where exercise is really, really important. And exercise is basically important with most vestibular conditions. If you have vestibular neuritis, it's also well documented that you want to keep moving. But of course, with vertigo, there becomes this commonality, just like low back issues and other problems where people get a fear avoidance syndrome. Because, lots of people have the experience, I went to the store and I turned my head and I got vertigo and then I was throwing up for hours. So the last thing they want to do is like move their head quickly. They don't want to go to the store. They don't want to be out and about. And so then they tend to isolate themselves, which sometimes can be one of the worst things we can do. And then on the autoimmunity, we would say, and good morning to everybody who's joining. On autoimmunity, I would reference the author Chiarella. Chiarella, Chiarella, I believe, is an endocrine ENT researcher, and Chiarella did a lot of research on Hashimoto's thyroiditis. That's where the immune system attacks the thyroid. And just so you know, because we talk about Hashimoto's every week, to some extent, Hashimoto's has been shown to cause basically decreased vestibular responses in like 44.8% of Hashimoto's patients. So somehow the Hashimoto's process seems to damage the vestibular labyrinth or the vestibular nerve to a certain degree. So if you just have nebulous dizziness, that's where I've said for a long time that you want to be checked for Hashimoto's. A lot of people say, well, my thyroid was checked. If you have your thyroid checked, just know they probably just checked a thyroid hormone. They didn't check you for the immune counts to the thyroid gland itself. But Chiarella then was looking at Meniere's patients, and she found that over half of Meniere's patients either have Hashimoto's or an non-organ specific autoimmune process, meaning they have generalized autoimmune inflammation. And again, is the inflammation then causing the vestibular system, the endolymphatic sac up here, not to drain through that duct? So it's thought is the inflammation clogging the pipe. And it can be allergic inflammation, it can be autoimmune inflammation. So if you have Meniere's and you're looking at statistics, you have over a 50% chance of having a gluten allergy just with skin scratch testing. That's a very basic test that's really, there are more sophisticated tests for gluten intolerances. So over 50% of you have some issue with gluten, and over 50% of Meniere's patients have some sort of autoimmune process. So if you haven't been checked for these things, you really want to be checked. If you know someone with Meniere's, you need to tell them to be checked, in my opinion, because if you can maybe help them to calm down this immune inflammation, maybe the inner ear is not going to get damaged as much and swell as much and contract and swell and contract and cause these issues with hearing loss, ringing in the ear, and vertigo. Maybe it won't be as bad. So your thoughts on that, Kathy?
That makes sense to me. So does that cover what we were talking about, the inflammation affecting the hydrops, or is that something different?
Yeah. So basically, endolymphatic hydrops is the term referred to the swelling process involving the endolymphatic sac, which is basically involving your cochlea and your vestibular apparatus. So yeah.
Okay.
Yeah.
Okay. Again, I think you've given us a lot of good information.
Yeah, I'm glad we did today, because I think with the poster and the brain model, I hope this came together better. The one last little piece I will mention is that if you do have Meniere's, also be aware that Meniere's has a heavy association with BPPV, which is benign paroxysmal positional vertigo, i.e. the ear rock. So what you heard us saying earlier in today's broadcast about the pieces of calcium carbonate and they dislodge, well, this occurs more commonly in people who have Meniere's disease. So it can be confusing, and this is where the timing is really important, because you may have Meniere's disease where you have attacks of vertigo lasting 4 hours, and then you may have attacks of vertigo lasting a minute. And because, which makes sense that you're kind of disconcerted by the attacks of vertigo, you may have an attack of vertigo for a minute and it really throws you off emotionally and it creates a lot of anxiety. Well, that vertigo can be much more benign than the whole Meniere's attacks. So, and those can be addressed with particle repositioning maneuvers where you can have the epile or you can have other horizontal canal reposition maneuvers done to help get the crystals back into where they should be so you don't have as much vertigo. So that's the last little piece I kind of wanted to impart. Before we finish. Let me see if we have any other questions. Oh, good. And we're getting positive comments about the visuals, so that's great. Fantastic. Okay. Anything else, Kathy?
No, I think that's about it.
Okay. Well, thank you everyone for joining. Have a lovely weekend. be safe out there, and we'll be back next week with another topic. Anything you want to hear about, let us know, and we'll go from there. Okay. Let's see, we'll end that one, and this one, and that.